Hi, everybody. Congrats. We made it to the last one. Thank you for being here with me. I'll give a short version of the talk on the next slide in case you're done. And you can ask me about it later. But I tend to get excited when I start talking, and I'll go too fast, and this won't be a half hour, so don't worry. I am an adult neurologist, and so what brought me here to this conference, I'll tell you in the next few slides. The background of the slide is what I spend. I split my time between seeing people with MS and adult leukodystrophies, and also I'm a scientist in the lab, and these are oligodendrocytes and myelin regenerating, because we need something to fix brain lesions, right? So I'm not talking about that here, but that's, a future standard of care. I have some disclosures because of what I've been able to diagnose in this genetics clinic. That's myelin, by the way. Myelin is beautiful. Okay. So I'm going to introduce you to what an adult diagnostic leukodystrophy clinic is, the strategies to diagnose and longitudinal management for adult leukodystrophies, and then how that applies to adrenal leukodystrophy, and the symptomatic treatment and longitudinal care in this clinic for adults, and future directions. And the short version of this is I am here because this is on the newborn screen in Pennsylvania, okay? So let's get into this. So I started sort of launching into genetic disorders as a neurologist when I was a fellow at Hopkins, and we would have case conference once a week where there was someone who just didn't fit the MS diagnosis, NMO, MOG, infections, systemic autoimmune disorders. And we're like, so they're like, I don't know what it is. And so what's the next diagnostic step? And so I wanted to know, could we do genetic testing on adults? And it's not a coincidence I asked this question. I worked on a leukodystrophy as part of my PhD. So I knew you could do it. I just hadn't been trained in how to do it. So that's the first thing. Adult neurologists aren't really trained in how to do this, okay? And so I got to hang out with very doting mentors like Dr. Fatimi to show me how you do this in the leukodystrophy clinic, and Dr. Vanderver at CHOP, just sort of casually actually, what do you guys do? What sort of testing do you send? What do you need to have in place to get this done? I am a basic scientist. I like to think about things in terms of all the cells. So I'm just gonna show you a slightly different way that I think about how the brain works. I think it was brought up earlier today that we don't know which part of the brain and the spinal cord is important and when and how it gets affected. So just to talk about the cells, right? So you've got neurons, and they send these beautiful projections all throughout the body to send signals. And to make that efficient, you need myelin. That's the green cell coming off the oligodendrocyte. These are super complex, amazing cells you're stuck with for life, so you need them. But there's actually this pool of precursor cells that can replace those oligodendrocytes if you need them, and they're there throughout life. There's immune cells in the brain called microglia, and there's astrocytes that touch and interact with all of these cells, and the vasculature to make sure everything functions properly and communicates with each other. And then running through everything are the blood vessels. They have a barrier with endothelial cells. And when that barrier breaks down, that's when you get gadolinium leaking through into where you can find those areas of leakiness, okay? So all of these areas are actually involved in adrenal leukodystrophy. And even though I want to put everything in a box by cells, and you can do that for some disorders, adrenal leukodystrophy does not fall into boxes like I want them to, because I think in all of these cells and all of the parts of the brain and vasculature could be affected, these cases, because they're affecting a part of all of these cells, right? So we have a lot to learn about how this affects things, but in the clinic, how do we identify all of these disorders in adults? And so I had to start from the place of saying, well, what would I find by doing genetic testing? So there's specific types of disorders. Leukodystrophies are these genetic disorders that primarily affect those non-neuronal cells, glial cells, okay? That's what they're called that because they were thought to be the glue, but they actually do a lot more important things. There's this hereditary spastic paraplegia. These are these long tract. That is very similar and overlaps with adrenomyeloneuropathy symptoms. And then this broader term, genetic leukoencephalopathy, doesn't really care who caused it to begin with. It just involves all these things. So I like to use that term. And so it turns out, when you're kind of approaching people that come to you that have undergone these long diagnostic odysseys, right, and are just want an answer for what's going on, you have to figure out what is the reason that they were thought to have other things versus what else could they have, right? And so progressive motor weakness, spasticity, bowel bladder dysfunction, cognitive impairment, apply to both rare genetic disorders and acquired disorders. There's similarities in imaging. You can have bilateral and progressive white matter lesions and gadolinium enhancement in both. So that actually doesn't differentiate it. There are some aspects of history that, push you in the direction of it could be genetic, right? If it's a rapid progression that's unexpected, if it's an early onset. I don't actually know what early onset means in the adult world. Is that 20s, 30s, 40s? I don't know. We'll see. Now that at my age, I'm gonna say 50s can be right. But also if you have involvement of other symptoms like peripheral neuropathy or systemic involvement, that's sort of like something else is probably going on. If they're symmetric, if they're big and kind of blowing up, they look unusual. If there's spinal cord involvement, you don't actually have to have lesions to have spinal cord involvement. They can be atrophy over time. And it anytime something comes up that's confusing, maybe it's something else going on, right? You have to sort of like start to think outside of that box. And so, somewhat naively, about 7.5 years ago, I started this clinic at Penn. I see people in clinic 1/2 day a week. Otherwise, I'm in the lab. And one of those, one per month, I started to say, send me your patients who have bilateral white matter abnormalities, clinical features that are atypical for more common diagnoses like MS and headache and vascular disease, or there's a family history, and you've done the workup and you're still not sure. And it turns out in this time, I've been referred from every neurologic specialty, all of them is the answer to this question, primary care doctors, genetic counselors, medical genetics, social media. There's Facebook groups, for like women neurology Facebook groups saying, help, I have a patient, I don't understand what to do. I have had referrals that way. And so when people come to see me, we do our version in the adult world of what we can do for a multidisciplinary evaluation. And so I see people with a genetic counselor. I started with Tanya Bardakjian and now with Aaron Baldwin. And our genetic counselor, and I know I'm kind of preaching to the choir here, you know these things, but it's not always known in the adult world that you should do these things. So when I give grand rounds and I say this, it's to be very clear that this is what you have to do this right. And so our genetic counselor helps with the family counseling, discusses risks of genetic discrimination, generation of the family tree, obtaining insurance approval, and trio testing for the family if we can. And the types of testing that we send are generally broad-based. I only send targeted gene sequencing if I already know that's in your family. Otherwise, we're sending panels and whole exome or whole genome. Because while things show up more pattern recognition like in kids, in adults, you don't follow rules. So we came up with this very simple, not too hard approach to make these diagnoses. I'm just kidding, this is not at all simple. But to sort of break it down, this top area that I've outlined is what we do in the MS clinic. We see white matter lesions. Does it look like it could be genetic? No, we'll send the basic labs that we think could push us in the right direction for MS and then treat as appropriate. In the pediatric leukodystrophy clinic, things have a pattern on MRI very often, and when you work with wonderful clinicians, like I have gotten to learn from, you can see these patterns and show up, know what it is ahead of time sometimes, and you don't have to send this broad-based testing. I didn't know any of those things, I still don't with some rare exceptions, so we just have to send broad-based testing, look at all the biomarkers, and hope that we find something. And I can say, now that I have seen examples of several disorders in clinic, even in the same family, nobody shows up the same. And I do this because there's a lot to learn as a site for the Global Leukodystrophy Initiative, this NIH-funded consortium, where I offer everyone who comes to my clinic the opportunity to enroll in the Myelin Disorder Biorepository program, so even if they're diagnosed or undiagnosed, they can contribute to ongoing research. And so I think I was one of the first adult sites for it, but you can see there are more now, and it's growing, so this is wonderful. Lots of ways to learn more going forward to get clinical trial ready for many disorders. And so now to kind of break down, what did I see? So I started in November, you can see. I got a trickle in of trying to convince people to come see me, and this has increased over time, right? This cohort includes, and I'm gonna start off and say, the name of my clinic, Undiagnosed White Matter Disorders, Adult Neurogenetics Clinic, okay? It's a mouthful, but I had to start somewhere. So this includes undiagnosed people presenting for evaluation. And of the people that we sent genetic testing, we diagnosed about 25% of them. And so I learned about those disorders when they showed up, right? Because I hadn't really been doing that as part of any of my training to take care of genetic disorders, so we learned as we went. We also diagnosed acquired disorders because I send those rare neuroinflammatory markers just in case that's been missed, and we have treatments for them. And then we also had a lot of people show up that were previously diagnosed, and they just wanted to be taken care of in an adult clinic. So I had to change the name. It's now the Penn Medicine Adult White Matter Neurogenetics Clinic because they're not all undiagnosed. And these are actually the cohorts of different types of leukodystrophies and other disorders that I've seen. And you can see what's at the top here, okay? So there's one who's a clear winner, X-linked adrenal leukodystrophy. And if you sort of break this down by year, it's been a trickle over time, and it's increasing. And I think I just found there's a paper from the Pennsylvania Newborn Screen and the outcomes that was up to 2021, where they found, I think, 21 boys and 23 girls and then their families. I think some of these numbers are their families starting to come in to see me. And who I am seeing is almost 50% male and female. All right, so in general, when we make a diagnosis, what do you do next? So we do genetic counseling for the diagnosis and the implications for family members. We look to publish guidance and consensus guidelines, if they're available, for disease-modifying or symptomatic treatment. We start appropriate baseline and surveillance testing. We start disorder-appropriate symptomatic treatment. We refer to the appropriate foundations if they're available, and we send them to a center with expertise, because I can't at this point claim I'm an expert on any of these things, as I'm learning and finding them as I go. And then we look at clinicaltrials.gov to see if there's any trials ongoing and reach out to the people that are running them. So one of the first things that I've learned and I share with others is that there's guidance out there already, right? I don't have to make it up. And so in 2022, there's this international consensus guidelines for X-linked adrenal leukodystrophy for symptomatic and multidisciplinary care. And so I definitely have drawn from this experience, but for someone who sees people that are 18 and older, there's not a lot on here that says, like, this is what I'm supposed to be doing for people, right? Even though it's sort of the implications of what's said there. And so over this time, it turns out in this rare disease, niche of things, if you've seen a few people, you're an expert. So we got invited to work on consensus guidelines for some other disorders, APPD, which is an adult onset disorder, and MLD. And then I realized that if there aren't any, you make them. And so the first genetic counselor I worked with had this idea, like, maybe you should tell adult neurologists what to do. So we did. We got together with people that are here and other people that are not here today to say, hey, neurologists, this is what you do with adrenal leukodystrophy. So, and this was written by one of my MS fellows that I work with, who's now at Children's National in DC. And we found that most of the people that were coming to us were coming through newborn screening. So these babies were seen at CHOP, and my colleagues at CHOP at the Leukodystrophy Center would send over their family members. Now, who in the family was coming over to see us, right? So this is something that now, after having listened to the past 2 days to look into a little bit more deeply, I think I could say from vibes of what I remember, is that it's usually the family member who was symptomatic who now has an answer, right? That's the first person who comes to see me after this has been figured out. The last person is the parent, I would say, because they are dealing with the effects of having had a kid come up on the newborn screen and what you do about that, which is fine. But we're going to see everybody who wants to be seen. There is more widespread use of genetic testing, and so some people have been sent to us because we sort of put down our flag and said, we see adults with this, so come and we'll take care of you. And then actually the endocrine clinic is where people have been sent over with adrenal insufficiency or workup for spastic paraplegia. All right, so this is what we recommended, and it was in the setting of thinking, and this is sort of a much more simplified version of what Dr. Eichler had as the overlapping phenotypes, is that even in adults who are coming to see us who are perfectly asymptomatic, you could develop adrenomyeloneuropathy, adrenal insufficiency, and or cerebral ALD. And so we made these very novel statements that you should have regular neurologic examination to identify and monitor for myelopathy and polyneuropathy and start symptomatic treatment, bless you. It's important to recognize this in women, that all the male patients presenting with cerebral ALD, AMN, or pre-symptomatic ALD should be screened for adrenal insufficiency, and we were specific about what to screen for. that you needed a diagnostic brain MRI with and without contrast and then annual surveillance in men. And this is important because the lesions can show up before symptoms. And so you can act before anything has been affecting their function. And there's so much support out there. We just listed everything out in tables, so it was easy to find. And then you can have ongoing treatment discussions once you've established these long-term relationships that you talk about aggressive symptom management that we have, but there's also potential therapeutic options for cerebral ALD if it's detected, and there's ongoing clinical trials. So how do you get linked up to that? And so just to kind of go through this in a little bit more detail, I'm happy to share if anybody wants to share this with their providers. But what you look for with adrenal dysfunction, and we've heard a lot of this today, so I don't really need to go into the details, but just to sort of lay it out, what could be signs of cerebral ALD, what you need to do for the testing in both men and women. And we've heard all these things today, and these are the basics, right? These are the absolute basics of what you should be addressing. But over time, I realized in taking care of people that we didn't include, like, when do you send an EMG, right? And something I do now, because it's clinically available, you can send baseline and longitudinal neurofilament light chain and even GFAP levels. GFAP is an astrocyte marker. I don't know if it's important, but if insurance covers it, and I can tell insurance that it's standard of care, because who's going to argue with me, and they having it, then this might be something that's important, and every person can be a comparison to themselves, right? Another test that I get in clinic, this is based on my experience with MS, is optical coherence tomography. It's a 5-minute test that measures the thickness of your retina. This could be a very sensitive measure of change to your neurons over time that's not detected on MRI. So we're just getting baselines and falling over time. And then how often and when should you check vitamin D and bone density over time? There's a lot of questions that you should ask someone about how they're doing with their function. And again, you've heard a lot of this already from various people. And those questions drive, do you need referrals to other specialists? So I've listed them out here. And under neurologists, I put the different specialties that I think match up. There's general neurology. Great if you can have a specialist in leukodystrophy, right? I think I'm MS in neuroimmunology, and I think that's an excellent fit because our specialty is designed to monitor a complex disease and give a treatment to prevent further lesions and look at many systems based on that, so that, you know, it's not that much of a stretch to think that this could fit nicely in there. But also neurogenetics and movement disorders often are seeing genetics patients in the adult clinic. Your primary care doctor, genetic counselor, psychiatrist, psychologist, neuropsychologist, therapist, urologist, physiatrist, PT/OT, GI, social worker, nurses, nurse practitioners, pharmacists, endocrine, nutritionists, and palliative care. Okay, so there's a reality check of what I can see in clinic. I'm in the Comprehensive MS Center. I'm joined by a genetic counselor as part of neurogenetics, and I usually have a fellow training in MS with me. And this is actually, like, has come to fruition. The fellow I trained last year is joining me once a month to clinic to see people because she thought that the experience of it was so great. So we're training more people to do this. So more is coming down the pipe. We also have access to social work, pharmacists, neuropsychologists, nurse and nurse practitioners. But I don't have the other specialists in clinic with me, and I don't see a way in the future, unless I get like an enormous donation to pay for everything. I don't really know how to do that otherwise. It can actually be very challenging in the adult world to find the right specialist. I've definitely had people tell me, have reached out to endocrinologists, and the office told them they don't see this disorder. Of course, they see adrenal insufficiency, right? So you just have to, like, find the right partner sometimes for who to send them to. An additional challenge that I'll raise a few times is this transition to adult care. Now, I've worked with CHOP with transition teams who can help make sure that people get in all the right specialties with the right people, but it is very hard to do that right and to make sure someone feels comfortable when it's not the same type of team approach as it is at a children's hospital, but we're trying to figure that out. So this part, I'm gonna just sort of fly through because it's the end of the day, but we actually laid out specifically all the things that each specialty can do. And I just want to highlight something like PT/OT. Like, sometimes I have to convince people to go to PT/OT. And people have said it doesn't help. And I think a lot of the reason is because if you go to a physical therapist who's not trained in a neurology does not have neurology-based training, you actually are not getting the type of help you need. And so sometimes I will make sure that I'm referring them to a neurology-based physical occupational therapist, or direct them to the National MS Society website where you can search for appropriate therapists that are in your area, and then reach out and see if they have the right training for what you need from them. All right, and so just a statement about treatment. So everybody here knows this already, but the imaging findings typically precede symptoms of active cerebral ALD. And in adults, the treatment option is an allogeneic hematopoietic stem cell transplant to halt the white matter inflammation, but this is associated with significant morbidity and cost. It can potentially stabilize the enlargement of lesions and even improve in the few people that have been reported with this. And the gene therapy is not an option for adults. So if you can convince somebody to do the bone marrow transplant in adults, that's what we've got. But a question that I have and ongoing is, who performs this on adults with cerebral ALD? I don't think that's a very straightforward question. I'm screening, and I have to kind of be creative about who I'm referring to if we find anything. So there's some challenges to the care of adults with leukodystrophies. There's a challenge to obtaining a genetic diagnosis. We're getting better, but there's still a lot of education about how to do this that needs to get out there. You have to build a multidisciplinary team. They might not be with you in clinic, but you can find all the people, even with limitations of insurance and limited understanding of a rare disease. We don't have all the same specialties in the adult world that the pediatric hospitals do, so we kind of get creative with that, to be honest. It is a challenge to transition to the adult clinic, but we'd love to take care of all of your healthy kids that have grown into adulthood and are doing fine and prevent anything else from happening. That's the goal, right? So you have to figure out how to do this ahead of time. And then access to treatments. Who's gonna do these stem cell transplants in adults when it happens? I think that's something that we have to be very aggressive in planning that out. So sort of outstanding questions. Are they underdiagnosed in adults? Yes. I don't know how much yet, we'll see. I think having it on the newborn screen is going to fix that for the most part, but there's gonna be a gap for a while for people still undergoing diagnostic odysseys. We need to improve our standard of care guidelines for adults, and in general for adult leukodystrophies. I'm working with the Standards of Care Task Force for Glia-CTN. I'm co-leading that with Jamie Frazier. One thing to bring up in particular is, what are the standards of care post-transplant in adults with adrenal leukodystrophy? That's something that would be good to explicitly lay out. I like to, in favor, and would encourage incorporating potential clinical trial outcomes into standard clinical assessments, having a standard EHR template to answer questions over time, and a part of the exam, to regularly perform standardized motor and cognitive measures, to standardize frequency of lab testing and surveillance MRIs with consensus-based sequences. And as was mentioned yesterday already, just this month, we came out with a consensus of what should be done for MRI in both children and adults. So you can have a multidisciplinary clinic that incorporates genetic counseling into this evaluation of undiagnosed white matter disorders, and we can diagnose adult onset leukodystrophies. The common features are that they're heterogeneous, even for the same disorder in the same family. They don't follow classic patterns, and that makes it difficult to diagnose. And there's often diagnostic delays and misdiagnosis as a result. For XALD, there's guidance for diagnosis and longitudinal management. It's defined, and it's in the process of being defined and shared within the community, but we have a lot that we can build on from there. The care involves an approach that can be challenging to build, but it's definitely possible with some creative ways to get around barriers. There's many research opportunities to guide treatment development. And then, to really build on this, we want to hear. And I've learned so much in the past 2 days, and thank you very much for inviting me to this. I've really learned so much. It's my first time here, and incorporated a lot of what was said already, but what do adults want for their diagnosis and care in the adult clinic? And happy to hear and discuss that going forward. And so it takes a village, even if it's just me at Penn seeing patients, but I have Erin and Christine, who helps organize me in the research arena, as well as our MS division and fellows and our research and neurogenetics team. So thank you.
Well said. I thought that was pretty good. I think I'm the only male patient that's here today, but I can say that's great information, and also try to get it into the heads of people that, well, it's more of a mental health thing that's huge, that you take all this information and try to process it, and you know, there's so many unknowns
Right.
that I would encourage them to find the community, reach out and talk to other men who have this, and it opens up a big world. You're going to see men who are in their 60s and 70s just living just fine, and you know, you're going to see also people your same age that might have it worse than you, but
Right.
you know, that community is very important. So
And I need to direct them to the podcast.
yes, absolutely. And the AMN Men group on Facebook. I'm an admin. So.
Thank you. There's just one question on Zoom, but first, I want to say how much I admire the way you've adapted your practice to what's come to your plate, and I just can't wait to hear what you have to rename your clinic to next based on it. So thank you for that. The question on Zoom is, what range of less scores do you recommend for adults to get bone marrow transplant? Or is that a question for the transplanters?
So that is a great question, and I don't know how to answer that yet. I just learned from Daniel Les this week how to score. I'm sort of catching on to these things. I think the right answer, I think, is the lower the score, the better, right? If the reason to do surveillance imaging is to capture the tiniest thing and then decide immediately what to do from there. And in the setting of adults, you know, if I uncover this, I'm going to basically, you know, call everybody in this room and have them, you know, direct me what to do, because I think there's just not enough information out there about what is the right thing to do. But earlier the better. Surveillance MRIs have to be done. We said annual. This is something that you need to come up with, like, with your doctor about what you feel most comfortable with all of this uncertainty. But, you know, if you can get it ahead of time, that would be ideal.
Thank you.
Thank you.